Today, we're going to look at an age-old condition known as leprosy. This is the outline of the lecture: introduction, etiology, epidemiology, pathogenesis, clinical manifestation, reactional states, investigations, cause, and treatment. Leprosy is also known as Hansen's disease. It is caused by Mycobacterium leprae or Mycobacterium lepromatosis. This is a chronic granulomatous disease acquired during childhood or young adulthood. Common sites involved include the skin, peripheral nervous system, upper respiratory tract, eyes, and testes. Transmission is via droplets. Various types of leprosy represent the spectra of the host immunologic response based on cell-mediated immunity. This is the Ridley-Joplin classification of the types of leprosy. So just going through tuberculosis or TT, patients have one or few erythematous lesions or hypopigmented patches or plaques. Nerve thickening is possible with hypoesthesia, and the slit skin smear is negative. Whereas the next level is borderline tuberculosis or BT. Here you have few erythematous lesions or hypopigmented patches or plaques. Patients may present with hypoesthesia and the slit skin smear may be positive. In the mid-borderline BB type, there are few or many erythematous lesions or hypopigmented patches or plaques. Patients present with hypoesthesia and the slit skin smear is positive. For borderline lepromatous or BL, there are few or many erythematous lesions or hypopigmented patches or plaques. Nerve thickening is possible with hypoesthesia or peripheral neuropathy, and the slit skin smear is positive. Lastly, for the lepromatous LL type, there are many erythematous lesions or hypopigmented patches or plaques. Patients may have peripheral neuropathy, and the slit skin smear is positive. This is a picture to illustrate the cell-mediated immunity and the bacterial load across the different spectrum. So you can see here in TT, the bacterial load is low and the cell-mediated immunity is high. As you move across the spectrum, from TT to BT to BB to BL to finally LL, the cell-mediated immunity decreases while the bacterial load increases. On the other hand, for ease of use, the WHO classification has been implemented in order to make things easier for workers on the field and especially to institute treatment. So this is only divided into two categories, which are paucibacillary PB or multibacillary MB. In the paucibacillary or PB type, where slit skin smear and skin biopsy are not available, often they use the lesion counts as a criterion, and here there are less than 6 lesions and slit skin smear is negative. So in the older Ridley-Joplin classification, this usually covers the TT and the BT types, and in the BT type, you can have a type 1 reaction. Whereas for multibacillary MB type, there are often more than or equals to 6 lesions present with a slit skin smear positive. And you can see in the older Ridley-Joplin classification, there are 3 types included under the MB type, which are the BB, BL, and LL. And you can see the different type of reaction types moving from type 1 and further along the spectrum towards a type 2 type of reaction. This will be illustrated further. Let's talk about etiology. So Mycobacterium leprae is an intracellular acid-fast bacillus. It reproduces at cooler temperatures, 27 to 30 degrees Celsius, and cannot be cultured in vitro. It infects the skin and cutaneous nerves and grows best in cooler tissues such as the skin, peripheral nerves, anterior chamber of the eye, upper respiratory tract, and testes. Mycobacterium lepromatosis was discovered in 2008. It has been found in Mexico, the Caribbean, and in Singapore, and this causes diffuse leprosy. In terms of epidemiology, leprosy is often found in the developing world. These are the risk groups: close contacts with patients with untreated active multibacillary disease, as well as persons living in countries with highly endemic disease. The incidence peaks at 10 to 20 years and prevalence at 30 to 50 years, and it is more common in males. The pathogenesis depends on the host's capability to develop cell-mediated immunity. The organism is capable of invading and multiplying in peripheral nerves, as well as infecting and surviving in endothelial and phagocytic cells in many organs. Subclinical infection with leprosy is common among residents in endemic areas. Incubation period is long, ranging from 2 to 40 years, but commonly around 5 to 7 years. The onset is insidious and painless. First, the disease affects the peripheral nervous system. Patients can have persistent or recurrent painful paresthesia and numbness. They can also have no visible clinical signs or transient skin eruptions, which may even blister, but patients lack awareness of trauma. In neural involvement, this can be accompanied by muscle weakness, muscle atrophy, severe neuritic pain, and contractures of the hands and feet. We now look at the clinical manifestations of tubercular leprosy, TT or BT types. So in these patients, there are few well-defined hypopigmented hypoaesthetic macules with raised edges, and size ranges from few millimeters to very large lesions covering the trunk. There's an erythematous or purple border and a hypopigmented center. The lesions are sharply defined, raised, and often annular, while the central area is atrophic or depressed. In advanced lesions, they are anesthetic, devoid of skin appendages such as sweat glands or hair follicles. It can affect any site, including the face. For TT, lesions may resolve spontaneously, and this is not associated with lepra reactions, whereas for BT, it does not heal spontaneously, and you may have type 1 lepra reactions. In TT or BT, for nerve involvement, patients may have thickened nerves on the edge of the lesion, as well as large peripheral nerve enlargement, including the ulnar, posterior auricular, peroneal, and posterior tibial nerves. Skin involvement may be absent in neural leprosy. Patients have hypoesthesia to pinprick temperature and vibration, as well as myopathy. This is a picture of a well-defined erythematous plaque in tuberculoid leprosy. Next, we look at borderline or BB leprosy. The lesions are intermediate between tuberculoid and lepromatous. These range from macules, papules, and plaques. There is anesthesia as well as decreased sweating. This is a picture of a patient with borderline leprosy. In lepromatous leprosy, LL or BL types, they have skin-colored or slightly erythematous papules or nodules. The lesions enlarge. New lesions occur and coalesce. Later on, patients develop symmetrically distributed nodules, raised plaques, diffuse dermal infiltrates, loss of hair on the lateral eyebrows and eyelashes, as well as a leonine facies, which means lion's face. Diffuse lepromatosis has been reported in Western Mexico and Caribbean. These patients have diffuse dermal infiltration with thickened dermis and is bilaterally symmetric, involving the earlobes, face, arms, and buttocks, less frequently on the trunk and lower extremities. On the tongue, they can have nodules, plaques, or fissures. Nerve involvement in lepromatous leprosy is often more extensive than in TT. Other areas involved include the upper respiratory tract, anterior chamber of the eye, and the testis. This is a picture of a patient with lepromatous leprosy with leonine facies, and you can appreciate loss of eyebrows and infiltrated facial skin. In terms of general findings, on the extremities, patients may have sensory neuropathy, plantar ulcers, secondary infections, ulnar and peroneal palsies, Charcot's joints, as well as squamous cell carcinomas in chronic foot ulcers. For the nose, they may have chronic nasal congestion, epistaxis, and destruction of cartilage with saddle nose deformity. For eyes, you may have cranial nerve palsies, lagophthalmos, corneal insensitivity. In lepromatous leprosy, the interior chamber may be invaded with uveitis, glaucoma, and cataract, while corneal damage can occur due to tracheasis, sensory neuropathy, secondary infection, and muscle paralysis. For the testes in lepromatous leprosy, they can have hypogonadism. Complications of leprosy include squamous cell carcinoma in chronic neutrophic ulcers on lower extremities. These are often low-grade and can metastasize to your regional lymph nodes and cause death. Another complication is secondary amyloidosis, especially for hepatic and renal involvement. Reactional states or lepre reactions are immunologically mediated inflammatory states occurring spontaneously or after initiation of therapy. For type 1 reactions, patients have acute or insidious tenderness and pain along the affected nerves, associated with loss of function. The skin lesions are acutely inflamed, and patients have edema, especially on the hands, face, and the feet. They may complain of pain and ulceration. This is the picture of a patient with BT leprosy and type 1 reaction. In type 2 reactions, also known as erythema nodosum leprosum, ENL, this is seen in half of LL patients, usually after initiation of treatment, generally within the first 2 years. They have massive inflammation with erythema nodosum-like lesions, as in painful red skin nodules arising superficial and deep. They may have abscesses or ulceration, and sites affected include the face and extensor of the limbs. This is a picture of the nodules in ENL. Lucio reaction often occurs in patients from Mexico or Caribbean with diffuse LL. They have irregularly shaped erythematous plaques which resolve spontaneously and have necrosis with ulceration, appearing as shallow, large, polygonal sloughing ulcerations on the legs. This is a variant of ENL secondary to arteriolar occlusion. Investigations in leprosy include slit skin smear, culture inoculated into the mouse foot pad, PCR, serology where you have IgM antibodies to phenolic glycolipid 1, and skin biopsy. What is slit skin smear? Here you're looking at 3 to 6 sites including the earlobes and active skin lesions. You disinfect the site with alcohol swab and allow it to dry. Pinch the skin between the thumb and index finger and perform an incision 5 mm long and 2 mm wide with a size 15 blade. Next, scrape the inner surface of the wound with the blade held at a right angle to the incision and transfer the material to a clean microscope slide. Smear in a circular fashion, roughly about 5 to 7 millimeters in diameter. So it is most difficult to manage changes secondary to neurologic deficits, as well as complications can occur, including secondary amyloidosis with renal failure and lepre type 1 reactions, which are 2 to 4 months in BT and up to 9 months in BL. Type 2 or ENL reactions occur 50% in patients with lepromatous leprosy and 25% of BL cases within the first 2 years of treatment. ENL may be complicated by uveitis, dactylitis, arthritis, neuritis, lymphadenitis, myositis, and orchitis. Lucio phenomenon can occur secondary to vasculitis with subsequent infarction. These are the principles of treatment. Multi-drug therapy, MDT, to eradicate infection, to prevent and treat reactions with prednisolone or thalidomide, reduce the risk of nerve damage, educate patient to deal with neuropathy and anesthesia, treat complications of nerve damage, and to rehabilitate patient into society. This is the typical MDT or multi-drug therapy used. For adults, the drug is rifampicin, clofazimine, and dapsone. And for MB, the duration is given for 12 months, PB for 6 months. And then for different age groups, the dosing is varied based on their age as well as weight, if they are less than 10 years old. For second-line treatment, in patients resistant to rifampicin, you may use a combination of ofloxacin, minocycline, and clofazimine, or ofloxacin, clarithromycin, and clofazimine. For patients resistant to rifampicin and ofloxacin, you can use clarithromycin, minocycline, and clofazimine. A multidisciplinary approach is often needed with involvement from dermatology, orthopedic surgery, podiatry, ophthalmology, and physical therapy. So we need to recognize and diagnose the different types of leprosy, to recognize and manage reactional states and complications, and to adopt a multidisciplinary approach, including MDT, in the treatment of leprosy. So with that, I thank you for your kind attention and have a great day ahead.